Hello and welcome everyone. Today we'll be discussing the management of interstitial lung disease in the ICU. Interstitial lung disease is a group of parenchymal lung disease with varying inflammation and fibrosis. In ICU admission, they often get admitted because of respiratory failure. The challenges that we face is in the diagnosis and the management of this complex disorder. ILD is classified into fibrosis predominant ILD. The example is idiopathic pulmonary fibrosis and inflammation predominant ILD. In this, it is characterized by more ground glassing in the imaging. So as you can see here, there is diffuse interstitial thickening, which is indicating fibrosis. This B here highlights traction bronchiectasis, shown here in the red circle, where the airways appear dilated due to the fibrotic tissue pulling the bronchial walls. It shows honeycombing in this blue circle, which is characterized by clustered cystic air spaces, which is a hallmark of advanced fibrosis. These findings are strongly associated with usual interstitial pneumonia, that is UIP, which is commonly seen in idiopathic pulmonary fibrosis. It shows extensive interstitial thickening, as you can see over here. These features together confirm the diagnosis of fibrosis predominant pattern in the interstitial lung disease. So this pattern is consistent with fibrotic type of ILD. Now this one is a slightly different. If you look closely, it shows mild interstitial changes without overt fibrosis. Now this is more suggestive of an inflammatory pattern. In the B, you can see subtle reticulations over here with slight heterogeneous lung parenchyma with early interstitial involvement. Here you can see a lot of ground glassing. The GGOs represent areas of increased attenuation on the CT that do not obscure the underlying bronchial and the vascular structures. These findings are indicative of inflammation, cellular infiltration, and or intra-alveolar filling. Now this pattern, if you see, is more characteristic of what is called inflammation predominant ILD. Idiopathic pulmonary fibrosis is characterized by the usual interstitial pneumonia pattern, as we saw. The prognosis is poor with 50% 5-year survival rate. And there are very high rates of admission requiring ventilatory support. Now, what is acute exacerbation of ILD? It is defined as a sudden respiratory decompensation within 30 days. The imaging shows new ground glassings or consolidations. The triggers are infections, environmental exposures, aspiration, but most likely infections. Now, regarding the interstitial pulmonary fibrosis versus non-interstitial pulmonary fibrosis ILD, the exacerbations are more common and severe in idiopathic. So in this you can see that there is a acute exacerbation. Here in the A, C and E is the baseline CT scan of the patient. Here you can see interstitial thickening and the reticulations that we have seen, the mosaic attenuations, which suggest that there is a baseline interstitial lung disease. However, on the B, C and D, you can see there is a lot of acute changes in the CT. You can see diffuse ground glassing, increased interstitial infiltrates. This represents that there is an acute exacerbation in the ILD. So, comparing the baseline with the exacerbation highlights the importance of longitudinal follow-up and helps us in making the diagnosis of exacerbation. So, how to diagnose it in the ICU? The most common way is HRCT, which is essential to identify the fibrosis and inflammation. The fibrosis indicators are reticulations, interstitial thickening and honeycombing. The inflammatory indicators are the GGOs, but you do need to rule out the other causes. Pneumothorax, pleural effusion, pulmonary embolism are important differential diagnoses. The role of bronchoalveolar lavage, the purpose here is to identify the infection, evaluate the cellular pattern. The benefit that we get is it helps us narrow down our differential diagnosis. However, the risk of hypoxia and bronchospasm, especially in critically ill, must be kept in mind. Regarding the usage, you can use it selectively to clear the diagnostic goals. Biopsy, transbronchial biopsy can be done with variable yield. There are risk factors like pneumothorax and bleeding. Surgical lung biopsy has higher diagnostic yield but definitely has its risks. So the recommendation is general to avoid in ICU these type of biopsies unless it is absolutely necessary for making some diagnostic or therapeutic decisions. Regarding the management, identify and treat the triggers, consider immunosuppression, optimize oxygenation and ventilation, give appropriate supportive care, manage the fluids, and address the pulmonary hypertension. Finally, follow a multidisciplinary approach so that all of the points can be addressed. Coming first to the immunosuppression, steroids are most important and the mainstay. Typical dose is 0.5 to 1 milligram per kg per day. Do require caution, that is increased risk of infection and other agents like limited evidence of cyclophosphamide and azathioprine. So steroids are to be used, but prefer hydrocortisone because infection is the most important trigger over here. But if the disease is very severe, you can go for higher dose of steroids, that is methylprednisolone 1 to 2 milligram per kg per day, which has shown to improve survival. Regarding the other agents like cyclophosphamide and all, they have been used and they do help in systemic sclerosis related ILD, while where the mycophenolate mofetil is seen as an alternative. Rituximab has shown promise in some cases. Regarding the role of oxygenation strategies, you can start with high flow nasal oxygen. It delivers high FiO2 with some positive pressure. It does improve the oxygenation, and the most important thing, it is comfortable to the patient. If the patient still doesn't develop improvement in oxygenation or continues to be breathless, you can go for NIV. The improvements that you can expect is improved oxygenation and ventilation. The limitations being there is no clear survival benefit of using this, and it's not very comfortable to the patient as well. So you can use it as an alternative to HFNC if the patient is not improving. But if the patient continues to be having more distress, then you can go for mechanical ventilation. The mortality rate becomes very high if the patient is intubated. The ventilative strategies are the common ones that we use, that is low tidal volume, 6 ml per kg to minimize the lung injury. Regarding the PEEP, high PEEP may not be beneficial over here because the lungs are completely damaged. Prone ventilation can be used, but limited data is available. It does improve oxygenation, and but this effectiveness in a setup like ILD is where there is no recruitable lung is not very good. Regarding the antibiotics, since infection is the most important trigger, empirical antibiotics should be started. Awaiting cultures, consider PJP, especially if the patient is immunosuppressed. Opportunistic infections should be suspected. Vigilance against fungal and atypical bacterial infection must be kept in mind. The role of antifibrotic therapy is limited. It does slow the lung function decline, but in acute exacerbation, it has got limited utility. Maybe for long-term use for after discharge, but in the ICU may not be of much benefit. Regarding the fluid management, the goals are similar, that is, try for a negative and neutral fluid balance. The importance lies in reducing the pulmonary edema and strain on the heart. These patients usually have pulmonary hypertension, so the management becomes very important. It is quite common in this setup. Regarding the treatment, go for careful fluid management, inhaled vasodilators, avoid the high PEEP and systemic vasodilators to worsen the VQ mismatch. You can go for ECMO over here, but it is just a bridge to transplant. The risks are extreme high risk of mortality over here. So individualize your decision and can be initiated if you're planning for a transplant. This is very important. Advanced ILD, unresponsive to treatment. This is the only therapy that is currently available. The challenges are evaluation must be done very urgently in the ICU, and the outcomes can be variable. Better if performed before severe deteriorations occur. A multidisciplinary approach is important. The team involved should include pulmonologist, intensivist, rheumatologist, and palliative care. The benefits is you get a comprehensive care and optimized outcome. The palliative care is a critical part over here because the symptoms may not improve and the patient may be in a downhill course. So the quality of life decisions become very, very important. Regarding the prognosis, very high mortality rates, especially in the IPF patients, and predict as a poor outcome are the need for mechanical ventilation, severe hypoxemia. Survival is seen in non-IPF patients where the outcomes are slightly better. Regarding the future directions, the research needs are more RCTs in this field. Effective immunosuppressive therapy needs to be evaluated, biomarkers for exacerbation, identifying them for early detection and management, and clinical trials need to be conducted on the therapies and patient monitoring. So the take-home message is this flow chart where the management for ILD is to be done. Assess for the non-parenchymal causes first, that is, rule out reversible contributors like pneumothorax, but pleural effusion, pulmonary embolism before you focus on your management of ILD. And in the acute exacerbation management, go for steroids plus minus the immunosuppressive therapy, treat the infection, go for a negative fluid balance, and manage the pulmonary hypertension. Regarding the hypoxemia, start with HFNC, which is preferred over here. NIV, if the patient is already hypercapnic or not improving with HFNC. If the patient is getting distressed, then go for mechanical ventilation, low tidal volume with low PEEP. Prone ventilation and ECMO can be used as a bridge to transplant. Thank you for your patience.